Hello, welcome. My name is Dr. Jamie Ullman. I'm a neurosurgeon at North Shore University Hospital. I'm the director of neurotrauma and a professor of neurosurgery at the Zucker School of Medicine. I want to talk to you today about concussion, sort of the ABCs of concussion, and I hope it generates some thought and discussion. So yes, we're going to talk today about the ABCs of concussion management. I know it's been a hot topic now for a number of years, and a lot of publicity surrounding sports and whether kids should be participating in football as a result of some of the concussion risks that are associated with high-level contact sports. So certainly something that the Northwell system has responded to by developing a concussion management program. And I'm going to talk more about concussion, how to manage it, and a little bit about our program. So concussion is really considered what we call a diffuse kind of brain injury. And concussion is not necessarily being knocked out. It really is a transient alteration of consciousness due to an impact to the head. And interestingly enough, it doesn't even have to be directly to the head. It could be even below the head, somebody getting hit from into the chest when the head bounces back and forth. That could be an indirect impact to the head. And basically, on a molecular basis, it's really an alteration of ion channels and energy balance. So the cells within the brain sort of go into a crisis of energy. And this is what causes the problems with the alteration of consciousness or symptoms that are related that we'll talk about. And this actually can be associated with the normal head CAT scans. The CAT scans are done when some people come into the hospital and they are injured, and they may get a scan of their head to see if there's any blood. And oftentimes people who are just have a concussion may not have any associated bleeding. There are some immediate clinical signs. One of the immediate clinical signs is confusion, amnesia. Retrograde amnesia is when you're confused or just around the circumstances of the accident, or you don't remember anything around the circumstances of the accident. Some people will have an accident and say, well, the last thing I remember was I got hit by the car, and the next thing I remember is waking up in the ambulance. And that doesn't necessarily mean that the patient actually passed out or lost consciousness. It means that they just don't remember that period of time. Often people will be, if they lose consciousness, this may not be for very long, but then the next thing they remember is some time period afterwards. And therefore, that may not be an indication that they actually lost consciousness, but that they have amnesia for that period of time. Anterograde amnesia, and sometimes people can go to the hospital and not remember events after the accident. And then they say, well, you know, I don't really remember much of what happened while I was in the hospital. And meanwhile, they're awake and people are asking them questions, and they may say, keep repeating themselves or asking the same questions and maybe not remembering that they were asked questions by medical providers or by family members. So that's what we call anterograde amnesia. It's very rare for anyone to have a permanent amnestic syndrome. Usually these things are very self-limited, and they people end up remembering. What's possible is that after a particular accident, you may not actually remember all the events in the future, all the events of the accident in the future, because sometimes that memory could be erased. But again, it's usually for a relatively short period of time. In the history, a lot of people can report seeing stars or a whiteout or a blackout visually. So 90% of patients who experience concussion do not experience a loss of consciousness. So it even could just be a slight daze. And sometimes on rare occasions, people get concussion symptoms without having any of those immediate signs. So the pathophysiology is really what a pathophysiology is really what's going on in the brain structurally to actually be causing this to happen and the symptoms to occur from concussion. And so it's really what we call an acceleration, deceleration, and rotational injury. That the brain is housed within a skull cavity that's pretty rigid, but the brain itself is kind of like a jello mold. And it is also surrounded by a tough covering, but also sort of surrounded by a liquid medium. And so when the head stops due to an impact, the brain can continue to go back and forth within the skull cavity because it's not 100% relationship between the volume of the brain and what the volume of the skull can contain. And that brain can slosh back and forth. And it's that kind of injury going back and forth, which is acceleration, deceleration. The skull stops, the brain kind of oscillates, and then sometimes it can rotate around, and then you can get a cell energy crisis, release of neurotransmitters, which are chemicals which allow the cells to communicate and interfere with that cell communication. And then we do know that the vast majority of concussions are reversible and they're recoverable. And the vast majority of people who exhibit a concussion do recover from the concussion, but it may take some time. Other immediate or early clinical signs are nausea, vomiting, headache, dizziness, blurry vision, imbalance, light or noise sensitivity. And sometimes people can get what's called an immediate concussive seizure. If anyone has even witnessed somebody who has had a concussion, you may see them shake slightly. That could be a seizure that happens just because of the impact to the brain, and it doesn't necessarily mean, in fact, it doesn't mean that you are going to end up with a seizure disorder later on. It's usually just in reaction to the concussion itself and will likely not occur. If seizures do occur for some reason after the accident in the future, then someone would need to have medication for that. But fortunately, it's not a common finding for standard concussion patients. Headaches happens to be probably the most common clinical sign of concussion, but a lot of people get dizziness. Other signs include forgetfulness, feeling foggy, difficulty with concentration and or memory, changes in personality or mood, difficulty sleeping or sleeping too much. So it's that paradox of having a hard time trying to sleep, but then you're sleeping a lot because you're tired and that's what your body is sort of asking you or telling you to do. When do you want to seek medical attention or immediate medical attention? Whether it be going to your primary care doctor or to urgent care or to the emergency room. If you have repeated vomiting or projectile vomiting, say the vomiting is actually just you could vomit and it goes forward a distance as opposed to just dropping in front of you, that could be a sign that you have some problems with the brain and need to see a specialist or a physician immediately. If you're having trouble waking up or increased confusion or an enlarging pupil in one eye or worsening vision or falling due to imbalance, these things can indicate some issues that are related to your head injury that may not, that may need to be addressed right away. You know, such as having blood in the brain or requiring surgery, for instance. I'm not saying that everyone's going to experience that, but if you are experiencing that, then it's important to see the doctor. You could have a seizure that's not related to that immediate concussive seizures, say it happens sometime later on, convulsions or shaking the limbs, and that would be a sign of the seizure, someone not being aware of their environment. Worsening headaches, stiff neck or fever, not acting right or significant change in their behavior, or problems talking, such as slurred speech. There are different types of headaches that we may experience. Some headaches are related to potentially injury to the brain per se, as opposed to injury of the neck. If your headache is within the front and the sides of the head, we most often think that it's related to the concussive effects on the brain. And if it's in the back of the head, then it can be associated with neck pain and whiplash. So you could see actually this picture where the head is going back and forth, and the brain is just going to sort of hit the front part of the head and the back part of the head. And so with that, you can get neck strain or neck sprain. And as a result of that, that pain from the neck can actually travel up the back of the head or affect the back of the head, because you got muscle spasms, muscles in the back of your neck that can cause spasm, and as a result in that pain. There can also be pain at the exact site of the impact, which could be long lasting. You can get, for dizziness, it's really actually important to define what dizziness means. If when I have patients in the office, I ask, what does dizziness mean to you? Because some people feel that dizziness might indicate that they have vertigo, which is the standard definition of that is that the room is spinning around, or that you have, or you feel like you're on a boat, or that you're moving even though the room is not moving. So that kind of motion, which is part of the vestibular system, which is part of the ear nerves that help us with balance, that type of thing is called vertigo, as opposed to lightheadedness, which is more of a feeling that, maybe you're about to faint, or that you feel just a little off. You just, you feel like, maybe there's a little bit of buzzing. Those are potential signs of lightheadedness. And both are considered dizziness, but it's important to distinguish that, because vertigo has a treatment, lightheadedness, not necessarily a specific drug to treat that. Another symptom could also be ringing in the ears, which I didn't list there, and that's also a finding that a lot of people can get. So associated injuries could be skull fracture, blood in and around the brain, neck sprain, whiplash, as we just talked about, and spinal injuries. So we have to be aware that the head doesn't exist in a vacuum. It's attached to the neck. And we do, in circumstances, need to rule out other injuries depending on what a person is experiencing. And again, here's that picture just enlarged, just showing the action of what happens when your head jerks back and then goes forward. And this brain is really kind of moving within the skull until eventually the brain stops moving once the head stops moving. But there's a delay in that occurrence. So a concussion syndrome often resolves within a few days or weeks and can persist for many months. But everyone is different in how they recover. If you speak to a neighbor who had a concussion, their course might differ from the course of another neighbor who had a concussion. Some people may have had a concussion that lasted a few days, 1 or 2 days, and other people may be going on for a very long period of time. On average, concussions usually resolve within 8 to 12 weeks, but there are some fewer cases that may go on for longer periods of time. We like to try to remain optimistic that concussions will resolve within a period of time, but I can't really predict in whom is going to resolve quickly or in a more longer term fashion. We don't know, and that's very difficult, I think, to predict. The post-traumatic syndromes, such as concussion, can result in behavioral changes, irritability, psychosocial problems, poor insight, cognitive dysfunction, fatigue, physical symptoms, and these can persist for months. Some people may be a little bit more prone to getting further head injuries or concussions down the line due to some impairment of judgment and insight. So we always recommend that people remain cautious after they've had a concussion. Ineffective coping skills can also occur down the line: employment, family problems, other deficits with cognitive function, which means thinking, processing information, and these can persist for a long time in some patients. Fortunately, most patients exhibit recovery, as we said, but some patients can get these continued problems. Some patients down the line, when it's going on for a much longer time, a lot of the symptoms end up being more related to emotional issues as anxiety or depression, and that could easily take over and cause other problems, such as perceptions that your memory is failing, or even the concentration is not doing, you're not being able to concentrate as well as you can. And the reason for that sometimes is not often a memory problem per se. If we do psychological testing, the memory may actually be okay, but it's really the other factors, anxiety or depression, can cause you not to concentrate as well, not to focus well, and can then give you the perception that your memory is not quite as good. So therefore, we really do need to treat other things down the line that come up. It is thought that some pre-injury coping skills and stress may predispose to a prolonged syndrome of concussion. And this determinants of this prolonged syndrome could be the pre-injury psychological status, extent of the primary or secondary injury. If you do have associated blood on your scan, certainly that could indicate a different type of course. Socioeconomic and environmental factors, and post-injury levels of cognition, emotional adjustment, vocational ability. I mean, all of these things can be factored in. In some cases, even pending litigation, against in no fault or in against a worker, or work-related injury can sometimes result in enough stress to cause the persistence of some of these symptoms. So lots of factors can enter into the situation. So we have causes, can be from a fall, a car accident, struck by an object, an assault, a sports-related, could be contact, collision in combat sports, impact below the head, as we mentioned, with excessive head movement, or blast forces, which we're not going to go into, but military personnel and even civilian populations who have been subject to large blast forces. Those waves can travel through the air, and depending on how far you are from the blast, you can actually get a concussive effect from that. That will have a similar effect as a direct injury to the head will, in terms of producing a concussion. And let me not neglect to say that a large amount of head injuries can also be sustained during recreational activities or play. Like children not necessarily are only at risk if they're doing a contact sport. They're at risk riding a bicycle or doing other recreational activities. But of course, we don't want to stop living, and we want to be able to live. The whole thing is about trying to do things that will keep us safe. In relation to concussion, as you can see, this was a compilation of incidences of sports and the incidence of concussion related to those sports. So as you can see, at the very top of the list is football, and we're talking tackle football in particular, and then boys ice hockey. But then, of course, you got boys lacrosse and girls soccer. Girls soccer, it's theorized that girls may not have strong neck as boys, and therefore may be more subject to various injuries, including when the ball is headed in soccer. And girls lacrosse, boys wrestling to a little bit lesser extent, and girls field hockey. And then as you see, the lower risk sports are gymnastics, volleyball, and cheerleading and all that. Not that concussions couldn't happen in those sports, but there are certain known higher risk sports. So when a child or an athlete is injured during a game, the evaluation could be done by trained coaches and athletic directors or team physicians. And oftentimes anybody, not sports related, any cause that for concussion, will often see a primary care physician as their first contact, or an emergency room physician. Now, for sports related and specifically, there is a concussion evaluation tool, and it's called SCAT. And it's the International Consensus Conference on Concussion, the latest of which in 2016 was in Berlin. And they came up with the Sports Concussion Assessment Tool, and this is the 5th edition. And this is really meant to be copied and distributed to anyone. It's open access because it was felt to be very important in allowing people who actually are not medical providers to understand what a concussion is and how to try to diagnose that on the field if an athlete gets injured. There are red flags, observable signs, memory assessments regarding the game. A Glasgow Coma score is a special score that we use in head injury to determine how awake a person is, and addressing the cervical spine. The red flags that, say, an athletic trainer would need to look for is neck pain or tenderness, double vision, weakness or tingling or burning in the arms or legs, severe or increasing headache, seizures or convulsions, loss of consciousness, deteriorating consciousness, vomiting, and increasingly restless or agitated or combative. That's a red flag saying this person has been injured, and therefore that person cannot participate in play. But the fact is that with all of these screening assessments and looking at in the office, you can do a bunch of assessments here that we're mentioning on the screen, such as neurological screen and balance. All of that is to assess, a patient after they've had a suspected concussion. If a patient presents on the field, if an athlete is on the ground and they're confused or dazed, or they said they saw stars, then that person needs to be taken out of the game immediately. It's no longer a question of how much loss of consciousness you had, which used to be an assessment, but it also, a person needs to be taken out of the game. The previous assessments would be to assess people with how long they've been out for loss of consciousness, and that no longer is needed to diagnose a concussion. Loss of consciousness is now out as a important method of diagnosing a concussion. There are other symptoms, as we discussed, that are also important. What's important is for athletes to be aware of this and to recognize a concussion. As a result of that, they should be telling their trainers and their coaches, I think I had a concussion, because a lot of the athletes that just go back into play are putting themselves at more risk for having a head injury again in that game or in future games when they haven't necessarily recovered from their initial concussion. So there's also a child SCAT-5, and that is pretty much the same, but you also need a parent report, so it accounts for that. When the person is in the office, we look at various things, such as the mental status, meaning, are you awake? Do you know what's going on? The pupils, we look at the eyes to see if they're reacting to light. Eye movements, we check eye tracking. Some people with concussion may have impairment of being able to follow a finger. And then nystagmus is when you look to one side, there may be beating of the eye. And that's something that may indicate that there's some issue with the vestibular system, that ear nerve we talked about that goes to help with balance. and then examine the limbs for weakness, examine the balance. Here's an example of a tandem stance and somebody putting their hands on their hips. One way of telling how your balance is to look ahead of you and then also close your eyes. Now, closing your eyes and keeping that stance is actually difficult to maintain balance. People with balance problems may not be able to do that. People with balance problems may not be able to stand with their eyes open. And then, of course, we have to test someone's ability to walk. Some people initially are so dizzy that they're holding on to walls. So we need to evaluate for that. We do, in patients, we can do a CAT scan or an MRI. All right, so on the left here, we have a CAT scan. This is same person, same cut. And on the right is an MRI. The white rim here is bone, and the black thing in the middle is fluid-filled ventricles. That's normal. Everything's in the middle there. There are two halves of the brain. The gray stuff is the brain. The bone is sort of eliminated from view in the MRI. You can see a little bit of bone marrow, but mostly you can see the brain, and therefore it may be a little bit more sensitive to seeing blood that's not fresh, but less fresh over a week or two period of time. For fresh blood, the CAT scan is the best image because it shows up as white on the CAT scan, not the bone white, but white within the gray brain or outside of the brain. This is just a funny, beautiful picture of what's called diffusion tensor imaging, which a lot of people have sort of adopted as a potential method of imaging concussion. Unfortunately, should not be used for prognostic indicators. This, to see whether or not a person's going to recover or how badly they're injured. That this is really technology that is not normally applied in the routine diagnosis of concussion. There was a CDC guideline on the diagnosis and management of mild TBI, TBI being traumatic brain injury among children, and it came up with some recommendations. This came out in 2018, and one recommendation is that you should not routinely obtain head injury for children. We do want to try to limit the amount of CAT scans and radiation from the CAT scans that children might get. Although one scan is not harmful, multiple or many scans can cause excessive radiation exposure, except if you're under 2 years, because they really can't give you any information. Vomiting, loss of consciousness, severe mechanism of injury, or if they're not awake and alert, the GCS is the Glasgow Coma Score. Anything less than 15, a person is not awake, alert, and oriented to every part of their environment. Or they have a skull fracture. So that's when you do a CAT scan. But of course, it's up to the doctor. If there's a concern, the doctor will decide. Some places have substituted MRI, fast scanner MRIs for CAT scans in children, and that's also possible. You could use an age-appropriated validated symptom rating scale like the SCAT, but there's also called impact testing, and athletes have undergone that in school as baseline and potentially after an injury. While those are very nice and can follow your progress, it's not necessarily used as a diagnostic tool. Serum biomarkers, we're going to talk about that, but these are chemicals within the blood that indicate whether or not somebody has had an injury to the cells of the brain. And it can detect structural brain damage that you could actually see on a CAT scan. And it is a way to assess whether a CT is necessary. And while they're saying it's in the research setting, this actually came out before two at-home or in hospital tests for biomarkers have actually become commercially available. So it's no longer research per se, but certainly it can be used commercially. But certainly I think we need to also put not only results of these tests, but also use clinical judgment as well. So we have to use our judgment as doctors. We should counsel patients and families that most children do not show significant difficulties more than 1 to 3 months. So we're talking about up to 80% of people, children and anyone else, adults, do recover within that period of time. but recovery can be variable. Each case is unique. And there could be factors that may delay recovery that we actually discussed about in children. Even previous learning difficulties can also factor on how long a person may take to recover. And we do, they said, observe more restrictive physical activity during the first several days, but I'm going to talk to you more about how we're getting away from sitting in a dark room and resting for a week. This is something we don't want to do anymore. We do want to increase participation in school without significantly exacerbating symptoms. So we may say no gym or recess, or we may say gym, but no contact sports or activities. And we need to assess for accommodations. Some kids may only be able to do a graduated return to school, maybe a couple of hours a day, and then increasing it to 3 hours or 4 hours, or may need to have extra time on tests, extra time for homework assignments. So those things we can assess and write notes to request these things. And non-opioid headache management is important because we don't want to give people narcotic drugs. We don't want to give them to children. We don't want to give them to adults as well, as much as we can avoid that, because it can only lead potentially to addiction and dependency, which is not good in the long run. Anyone who's got balance issues, what we call vestibulo-oculomotor dysfunction, should be referred for what we call vestibular therapy, which is balance therapy, essentially. And expert vestibular therapists can do wonders in helping the eye-foot coordination so that people can regain balance, and should provide proper guidance on proper sleep hygiene methods. And the attempt to determine the etiology of the cognitive dysfunction, if there is memory or concentration in issues that are going on for more than 1 to 2 months. We do need to give people time to recover, and that's why we don't want to go right into neuropsychological testing right away. Here's the FDA clearance of one of the blood tests, and then the second blood test in February 2018. And so these devices have now, I'm sorry, this is the same device, but this is the second device that was then released. And this is FDA clearance, and this happened in 2021. So what we have is that after February 2018, so probably after the writing in the press or publication of the CDC guidelines, we now have serum biomarker tests, and it's just testing certain chemicals within the blood. And so it might be able to determine, if you're on the fences, whether to do a CAT scan on somebody. The blood test might say, if it's positive for the presence of these biomarkers, of these chemicals, then yes, maybe we should be doing imaging like a CAT scan. So the current treatment is a rest period, but about 24 to 48 hours. Electronics can be used as tolerated. Some people say, don't look at screens. You can if you have to. Blue light is something that you may want to eliminate, especially at night, but also you want to make sure that you're not having a bright screen. You want to adjust brightness if that's what's bothering you. We need to manage headaches, vertigo, neck strain. We need to do a return to school, and return to work is incumbent upon the nature of someone's employment and their symptoms. So for work, if you're in a construction job and requires a lot of climbing, you are dizzy, then you should not be doing that until the dizziness and those symptoms resolve. We don't necessarily have to have you symptom-free in order to go back to a particular job. So it all just depends on those factors, whether or not you can go back to a particular job or whether you obtain another type of employment. But we like to, as much as we can, return people back to their original work, if that's at all possible. Sometimes it's not possible, sometimes, and many times it is. Now for returning to gym or contact sports or athletics, that's a 6-stage process. So for headaches, we give acetaminophen as sort of a first line, dexamethasone, which is a steroid drug, as a brief course, or methylprednisolone, which is also a steroid for acute headaches that are very severe, that are ongoing every day, that don't seem to let up. Steroids can sometimes help reduce that pain. And then in the later stages, we've been giving people drugs like topiramate, which is actually an anti-seizure medication, but in low dosages, we do treat concussive headaches with that. And then there are advanced migraine or headache management medications that at this point, I'm a neurosurgeon, I'm not a neurologist. Neurologists can treat headaches in a more complex manner, and therefore I tend to then refer someone to a neurologist. Occipital headaches, headaches in the back of the head, neck sprain, muscle relaxants we use, and we can use non-steroidals. It's very important, like for ibuprofen or naproxen, those types of drugs probably should not be used unless we're pretty certain that there's no bleeding. If somebody is on blood thinners and had a head strike, that may be an indication to get some imaging. So we in general, I feel comfortable that if we don't suspect any bleeding, whether it's clinically, whether looking at it as far as an exam or actually getting an image like an MRI, then we can do the non-steroidals. And then vertigo, which can be positional, meaning that when you get up, you feel like the room is spinning and you lay down, it's better, or any vertigo for that matter. Sometimes people are moving their heads or turning rapidly, and that's when they get the sensation of spinning. We have a medication called meclizine. It is available over the counter in the store at a higher dose, believe it or not, than what we can prescribe. I usually prescribe 12.5 milligrams. But the 25 milligrams is available in the store. Sometimes I even give vitamins, riboflavin and magnesium, which is riboflavin is vitamin B2. There's not really a whole lot of literature to suggest why these should help, but some patients have experienced some reduction in headache or improvement in a feeling of well-being. And so it's a supplement. In the majority of patients, it's vitamins and minerals. So perhaps that could be an alternative treatment as well if people are wary about taking other prescription medications. Good sleep hygiene, as was mentioned in the guidelines, is very important because of the fact that people may end up sleeping too much. Often it's during the day, and then they lose sleep at night. And then your cycle is all off. And it's very important to try to restore the normal sleep cycle. It's great to do it without any kind of supplements, but we do recommend at times melatonin, which is a supplement. It's not a drug. It's not meant to sedate you. It's actually meant to act on a hormone that already exists. And it's produced by a gland, structure called the pineal gland. It's in the back of the brain, and that helps your sleep cycle. So if you're supplementing the melatonin, it may help restore that sleep cycle. Do not exceed 3 milligrams 30 to 60 minutes before bed. There can be side effects if you really take high dosages, more than 10 milligrams. So outpatient follow-up is very important. And then, of course, we talked about neuropsychological evaluation. If memory or concentration is going on for a very long time, I tell patients that you might be pleasantly surprised. It may be that just the stress of everything going on is really what's causing you not to focus and not to be able to remember, where you put your car keys or what you were going to do when you walked into a room, or other things, perhaps, or directions to a place. Maybe these are just some other factors that are accounting for that. And oftentimes we see that. And that may need medication if there is a high level of anxiety, or even some people experience nightmares from the accident. or some form of a post-traumatic stress disorder, those people really should have some psychological counseling. Even if you are having anxiety or you feel that you're getting depressed, psychological counseling can help tremendously. And sometimes a psychiatry referral for some therapy, including medications, to help relieve some of those symptoms. And then the memory might actually improve, and the actual testing might show that you're not having a memory problem per se, that your memory is actually good, but everything else is causing that to seem impaired. Active rehab is something that has come up, and that's very important. This was actually a statement that appeared in a journal called Neurosurgery, and it was a consensus meeting in Pittsburgh, Pennsylvania in 2015, and basically stated that strict brain rest is not indicated, may have detrimental effects. What we need is stimulation. We need both physical and mental stimulation in order to get our brains set to right. So multidisciplinary treatments offer the most comprehensive approach to treating clinical profiles associated with concussion. And the preliminary evidence suggests that active rehab may improve symptom recovery more than prescribed rest alone after concussion. It actually can be initiated pretty early, even the day of, but some people may really not be feeling well. So let's give them a couple of days just to rest. And then after that, we need to start stepping up some activity. Progressive aerobic exercises. Initially, it's got to be submaximal, subsymptomatic. We don't want to push through pain. We want to increase slowly and gradually the speed of intensity of walking or being on a stationary bike or even a rowing machine, and helping get your heart rate up, but not to the point where you're experiencing pain, just under that point where you're the max, where you're not having pain, and gradually that will improve. If you're experiencing pain, then lay back a little and reduce the intensity and the speed at which you're having that exercise, which you're doing that exercise, and then try to build up some more. Vestibular or the balance therapy and ocular therapy, if your eyes are askew and you're perceiving things differently, because some concussion symptoms can include not only blurry vision, but double vision or some odd appearances of objects in the room. And that could also enhance your recovery and also enhance neuroplasticity, which is a term a lot of people have mentioned, is the areas of the brain that are not injured to sort of take over function and be able to then compensate for what may be impaired. So this way, the brain now can function and get you back to normal. And here's just an article that showed that 118 adolescents were recruited in this study for early targeted heart rate aerobic exercise. And this is Dr. Letty, who's an important researcher in active rehab at the University of Buffalo for the State University of New York. And this doctor, along with his team, have really been at the forefront for analyzing the effect of exercise on concussion recovery, so that the results suggest that physicians should not only permit but consider prescribing early subsymptom threshold physical activity to adolescents as treatment for sports-related concussion, because the time the patients the patients who were assigned to aerobic exercise versus stretching exercise were more likely to recover within 4 weeks. So we see that there's some positive benefits. Now, for people who have imbalance, I try asking, if you're going to do exercise, go out walking, brisk walking, but go with somebody so there's someone to help you. If you do have imbalance, it's best not to be on a treadmill that's not supervised, because you can fall on a treadmill, and that could be very dangerous. I do recommend, if you have access to a stationary bike, that's one way that if you have some imbalance, that you can do the aerobic exercise without risking falls, especially on a recumbent or a well-made stationary bicycle. Dr. Letty and his team created the Buffalo concussion treadmill test, and the goal was that not to diagnose a concussion or clear someone to go back to sports, but it's a way to try to build up your exercise tolerance and your heart rate to help try to reduce the symptoms and ultimately get more oxygen to the brain and to heal the brain perhaps a little bit faster. So the purpose is to assess the degree of exercise tolerance, to identify the heart rate at which concussion-specific symptoms occur, to help establish a safe level of exercise for the treatment of concussion, to help differentiate between concussion and other possible diagnoses for concussive symptoms, such as neck pain, to identify physiological variables associated with exacerbation of symptoms, and the patient's level of recovery. But again, it's supplementary and needs to be interpreted with all the rest of the data. So how that works is that a patient is asked to walk on a treadmill. This is supervised, and they walk at a certain speed. And then they have to rate their degree of perceived exertion. Okay, and they have to rate this to the person administering the test. And then once they pass or they feel that they can go on, then they increase the incline of the treadmill. So this could also be a great way of knowing what your exercise tolerance is, but also at some point do the exercise training. And our STARS rehab facility do provide this type of aerobic training to young people, to athletes, and to adults who could benefit and don't necessarily have access to this type of aerobic therapy otherwise. So that is something that is available that we can provide. Return to play is a six-step process. We have the first step is no activity. The second one is light aerobic exercise, which is really the start of active rehab. And so these are what it entails, sport-specific exercises. And then if you're passing that without any symptoms such as headaches, then you go on to non-contact training drills. And if you pass that with no headaches, then you go on to full contact practice. And then if you pass that with no symptoms, headaches, dizziness, or other symptoms, then you can go back to return to your play or normal gameplay. It's important to note that each step is 24 hours. So if you've passed step 2, 24 hours later, minimal, then you can go to step 3. If you don't pass step 3, then 24 hours later, you can go back to step 2 and then do it again. If you're not passing these tests, then you're not ready to get back to play. And very important, because we don't want you to have these symptoms and go back into a contact sport and then be at risk for having other symptoms. There is something I'm going to go very briefly called chronic traumatic encephalopathy, which I'm sure a lot of you have heard of with concussion. And it's a syndrome of repetitive brain injury. It's been first diagnosed in a form in boxers, something called dementia pugilistica, and it has been seen in other sports, especially football. Here's an example of what we call not a direct impact to the head, but someone colliding into the chest. And this person is not doing very well in his face. It looks like he's had potentially a concussion as a result of that impact. But if you have continued impacts, and especially if you haven't resolved your previous concussion, then this could potentially cause damage to the brain. And a person who has chronic traumatic encephalopathy, this is tau protein. It's a breakdown product of brain cells that gets deposited in various structures of the brain. And the person on the right who has these dark brown stainings is someone who had chronic traumatic encephalopathy. On the left is a normal brain. So this is a person that has that disease, potentially because of repetitive injuries. But the signs of that could be short-term memory impairment, cognitive dysfunction, depression, emotional instability, some suicidality, impulse control, and may not be unlike symptoms that you might see with Alzheimer's disease. But it's so important to know that this is not inevitable after repetitive traumatic brain injury. More research is needed about the long-term effects of repetitive head impacts. It's not enough is not enough evidence to make a conclusion on this score. The key is caution, and we need to prevent further concussions because in general, 1 concussion is not great. 2 concussions is not great, and even further not great. The more concussions you get, it can't be good for you. So what we want to try to do is to prevent further concussions in general, especially while you're still healing. And so if you can be more cautious and try to avoid situations that can put you at high risk for further head injuries. There's always that debate, should people play contact sports and football? I think this has to be a discussion. You can still play football, but you have to understand those risks. Caution is the key. And I think what's happening is there is a movement in youth football to try to reduce the risks of concussion so that kids can play. The question is that when is a good age to start doing regular tackle football? And I think that's even not clear because there is a brain that's forming and developing up and through adolescence. When is really a good time? And when do you feel that you're not as vulnerable to these types of effects? And again, that's not clear. So it's a debate, and I think we can debate this for an hour or more further about whether or not to recommend contact or combat type sports for your children. And I do think it's a personal decision based upon discussion among family, among the children and the parents, and also the health professionals. There is prevention. CDC has a great site, their Heads Up program. There is the Heads Up football that I alluded to before. This is from the youth leagues, the Pop Warner leagues. They have demonstrated that if you're going to tackle, you're going to tackle head up, not with your helmet into the chest. These can cause what we call even subconcussive, which are not quite full direct concussive injuries, but the jolting of the head back and forth could cause little tiny unrecognized areas of the brain that could be having questionable function as a result of these types of forces. So we don't know that. So these are more safe techniques. Think First is an injury prevention foundation that was developed by neurosurgeons also, and I can, suggest that you go to thinkfirst.org for more information about concussion and prevention tips. And there's a second impact syndrome, which I'm not going to talk about too much, but this happens in very rare young people who have been in games and may have sustained a first concussion within a game, but went back into the same game, not having recognized that there was a concussion, and developed a significant swelling of the brain. It is very rare, but unfortunately it has happened on some occasions, and the news do report these cases. Why do we have a concussion program at Northwell? Well, the Zachary-Lystedt law was passed in 2009 in the state of Washington. Zachary-Lystedt was an athlete who was a teenager in high school and did suffer what we call a second impact syndrome after suffering an event that went unrecognized and then had a second event during a same game in the sports, and then ended up having to go for brain surgery, and fortunately has survived that and is now an advocate for concussion awareness and for brain injury awareness. And because of this law, we want to make sure, and all 50 states have adopted such a law, so that kids don't go right back into the game. They have to be immediately removed from the game. And this law said that there's no return to action until a athlete is evaluated and cleared by a licensed healthcare provider. So because this law and laws similar throughout the 50 United States are on the books, then concussion programs have sort of sprouted up in order to provide that licensed healthcare provider to help to clear people and to help treat people with concussions. Now, a lot of people who have concussion programs are well-meaning and are qualified. There are times where concussion clinics have come up, like staffed by a pediatric dermatologist with no real specific credentials, such as being a neurologist or a rehab doctor or a neurosurgeon or a primary care physician that deals a lot with concussive patients. Developing concussion programs simply because it seems like it could be lucrative. So Northwell has decided that we need to have a growing need for evaluation and management of concussion, education, and proper advice and treatment, and should be our primary goal. I was first initiated at South Shore Hospital by Dr. Sabini, who is the head of our concussion program. She's a physiatrist or a rehab medicine doctor at South Shore University Hospital. Wanted to take her local program and extend it into Nassau County. And at the same time, a group of neurology and me as a neurosurgeon wanted to develop a concussion program. So instead of reinventing the wheel or running parallel programs, we united in a cooperative program to create the Northwell Concussion Program. And it contains providers from rehab, from neurosurgery, neurology, ENT, orthopedic sports medicine, and pediatrics as well. We have pediatric rehab, pediatric neurology, and psychiatry can be referred, and neuro-ophthalmology. These are special eye doctors that concentrate on eye nerve injuries and function of the eye related to the nervous system. So our mission is to provide advanced concussion management and treatment in alignment with current evidence-based guidelines for athletes and non-athletic populations to facilitate maximum recovery and return to participation, whether it be work or play or school, most importantly. So these are the scopes and our objectives. This is all done under the direction of physicians. There could be physician extenders, advanced care providers such as nurse practitioners or physician assistants, but done under the direction of the physician, and medical care and rehabilitation services will be provided to our patients with concussions. We provide the community with early access to concussion management, and we provide expert concussion management for enhanced return to performance and quality of life for our patients. This is our goal, because you have people who are providers that have experience and know a thing or two about brain injury and how to treat that. And patient-centered approach with a team-based leadership. This is our number. This is part of our brochure. This is what our services include. We have our STARS rehabilitation program, which can do a return to play protocol if athletic trainers cannot do. The only thing they can't do is actual game practice, but they can simulate the exertion of a particular sport, and then you have to go on to a game practice, but we can clear up to a certain point. But if an athletic trainer is able to do that, then certainly we can then have them do that as well. But for us as providers to clear, we need to see that this return to participation or return to play has been completed. There may be some exceptions to the return to play depending on the circumstance of the athlete, but the vast majority are recommended to undergo such a return to play evaluation. So the conclusion is there really is a substantial need for access to expertise in concussion management. It's a multidisciplinary approach and it provides comprehensive care. So we want to be able to provide the therapy and the medical management. We may send you for an MRI if we think it's necessary. And this is our email address and this is our phone number. And if you have a concussion, please reach out. The emergency rooms at our hospitals, at say North Shore University Hospital, Long Island Jewish, they have our information and are a strong referral source for our program. So in any way, you don't need a physician to refer, you can refer yourself to the concussion program. And we are happy to answer any questions that you might have. You can email us at theconcussionprogram@northwell.edu. Thank you very much.